Hello, my name is Stuart Elborn. I'm Professor of Respiratory Medicine at Queen's University and a cystic fibrosis clinician and translational researcher. I'd like to thank the conference organisers for the kind invitation to speak at this symposium. I'm going to talk about microbial diversity and their potential use as endpoints for clinical trials. I'm going to focus primarily on a study that we have just published in the European Respiratory Journal and describe to you some further analysis we've been able to do on this study using next generation sequencing. I'm going to take you a little bit off piste because this study is in people with bronchiectasis not caused by cystic fibrosis, but who have chronic Pseudomonas aeruginosa infection. This cohort has allowed us to do some interesting analyses, but also to have a study design which you would not be able to do in people with cystic fibrosis, and I think has important lessons for us to learn for both diseases. These are my disclosures, and I have nothing to add to these today. Before going into data, I want to just remind you of some of the important concepts and definitions in interpreting next generation sequencing data assessing the microbiome. The microbiome itself is the totality of microbes and their genes in a particular niche. It is not a measurement of live organisms, but live and organisms that have left their DNA. I'm going to talk quite a bit about diversity today and want to just dwell on this definition for a moment. Diversity incorporates species richness, which is the number of species in a community, and the evenness of the species abundances within the niche. It's calculated mathematically, and a number of indexes are used, such as Shannon-Weiner and Simpson's index. I want to also just remind us that relative abundance, which is an important concept in interpreting next generation sequencing data, is not an absolute measurement, but is, as it says, an assessment of the relative abundances of particular taxa within a ecological niche. This is just graphically illustrated in this slide where I've used cows rather than bacteria. I come from Ireland, which is a very rural community, and we have a lot of cows. The panel on the right demonstrates a niche where there is richness. There are 5 different species or 5 colors of cows. There's diversity, and the different colors of cows are distributed evenly. So there, in this particular example, there is a balanced diversity. In contrast, in the panel on the left, there is dominance of one color with not much evenness and not the same level of diversity as the right-hand panel. So does this all matter? Well, there's an increasing burden of evidence which I think should convince us that there are important relationships between the microbiome and measures of disease severity in cystic fibrosis and indeed in bronchiectasis. This is a study that Leah Cuthbertson and Chris van der Gast have published with a number of us contributing samples from various microbiome studies from across the world. This is an interesting paper and I think is well worth a read. But I just want to pull out this one graph which demonstrates that using the Shannon measurement of diversity, there is a correlation with lung function. And you can see on the panels beside the correlation graphs that diversity is much lower in people with FEV1 of less than 40% predicted compared to those with moderate impairment of lung function or reasonably good lung function at greater than 70% predicted. The measurement of dominance is sort of an inverse of diversity, and in this CF cohort was primarily dominance by Pseudomonas aeruginosa, and it has an inverse relationship to diversity, with dominance being associated with impaired lung function. There isn't time today to talk about the importance of core and satellite taxa, but this is elaborated in the paper. In bronchiectasis, there are also, I think, some interesting relationships. This is a study we published earlier this year, looking at the relationship between CT scan scoring and diversity. And you can see in the middle column, the Shannon H column, which is the Shannon diversity measure, there is a relationship between HRCT total score, bronchiectasis, and parenchymal changes with diversity. And interestingly, for me, there's some early indication that measurements of inflammation, such as CRP and white cell count, might also have a relationship to microbial diversity in the airways. I'm now going to move on to share the results of the IBES study, which was designed to determine the efficacy of inhaled dry powder tobramycin by Paul Taylor on Pseudomonas infected patients with bronchiectasis. And the aim of the study was to evaluate 3 different doses and 2 regimes of TIP in reducing Pseudomonas aeruginosa density in people with bronchiectasis. As I said earlier, this study couldn't be done in cystic fibrosis, but because people with bronchiectasis, which is a very similar pathology in the airways to cystic fibrosis, are much less likely to be treated with inhaled antibiotics, and there is equipoise in terms of the use of inhaled antibiotics, we were able to do this study. Study design is complex. We had 3 cohorts to assess 3 different doses of TIP. Those doses are outlined here, and were increasing over the 3 cohorts. The first cohort was received 3 capsules once daily, the second 5 capsules once daily, and the third 4 capsules twice daily. But within each cohort, we had a continuous treatment arm and a on-off treatment arm, 28 days cycling, with 2 treatments with TIP and 2 treatments with placebo. This study design was a phase 2 study to inform the dose that would be potentially taken to a phase 3 program. And these are the headline results. All 3 doses of TIP reduced Pseudomonas aeruginosa sputum density from baseline to day 29, which was the primary outcome, because our main focus was on determining dose, and a secondary aim was determining regime, whether cycling or continuous. And as I think you can see clearly in this graph, there was no change in the pooled placebo within each cohort, but all doses resulted in a significant reduction in Pseudomonas aeruginosa sputum density. And there was the suggestion of a dose ranging effect, with the highest dose associated with the greatest reduction in Pseudomonas aeruginosa colony forming units per mil of sputum. We've subsequently, on these samples, been able to do a relative abundance assessment using MySeq, and also quantitative PCR to determine bacterial density using a molecular tool. And we get a very similar pattern with all 3 groups in the middle panel, really recapitulating the data in the previous slides, with a significant reduction in CFUs. But on either side, we have the relative abundance of Pseudomonas aeruginosa, which again parallels the CFUs, and the quantitative PCR, which is using the OPRL gene to determine the number of Pseudomonas aeruginosa using a molecular technology. I would just point out in the MySeq graph, the baselines are somewhat different, whereas in the quantitative assessments, the baselines are much closer together and all significantly reduce after treatment for 29 days. The study was longer than 25 days, and as I've described, had on-off and continuous parts in each cohort. And in this graph, which is rather complex, you can see the placebo group in black at the top of the screen, and the different regimes in red or blue below. The blue regimes are continuous, and the red, the cycling regimes. And there was a significant difference for continuous high-dose Pseudomonas, high-dose tobramycin, having a greater effect on Pseudomonas aeruginosa density than the cycling regimes. And I think you can see this pattern on this graph, and I will show you some further data to reinforce this. This is the relative abundance from next generation sequencing for the highest dose cohort, where I think you get a better picture of what we were able to achieve with this treatment intervention. You can see that relative abundance of Pseudomonas declined from 70 to 20 after 8 to 29 days treatment, and remained significantly below the baseline to day 123, which was the end of treatment, and then starts to rise again once treatment with TIP is stopped. These data can be analysed in many complex ways, and I'm going to give you a few examples of that over the next few moments. This is a microbiome analysis using principal component analysis, and it demonstrates shifts in communities during the treatment phases. In 3 graphs on the right, these demonstrate principal component 1 and 2, and without going into the detail of how this analysis is undertaken, I think visually you can appreciate on the day 1 graph all of the different treatment cohorts are on top of each other and are no different from placebo, which is in black, and again the continuous treatments in blue and intermittent in red. By day 29, all of the treatment groups who were receiving the tobramycin inhalation by powder, which was all of the patients at day 29, are distinctly different to the placebo group. All of the coloured groups are spatially different to the placebo group in black. However, when we get to day 57, where we've had 2 cycles, the placebo group and the cycling group, which has now had 1 month of treatment, are very similar, while the continuous treatment groups, all 3 of those in the blue circles and dots, are different from placebo and from the group who had received 1 month of TIP followed by 1 month of placebo. These can be also graphed using Kananakan analysis of the principal coordinates, and you can draw vectors showing trends. And in the other panel, this demonstrates that Pseudomonas dominance was associated with inflammation, microbial density and Shannon index were associated with non-pathogenic microbiota and less disease severity. And treatment intervention is associated with increasing diversity. We looked at a number of correlations, and in the next 2 slides, these are exploratory analyses looking at the relationship between diversity and particular bacteria. And the pattern in the top panel is that diversity is associated inversely with Pseudomonas aeruginosa, but is positively related to Streptococci, Prevotella, Villanella, And these are microaerophilic and anaerobic bacteria, which are of interest because they are present in the healthy upper airway. Interestingly, there was not a strong relationship with any of the bacteria and their relative abundance and measurements of lung function. There's also some signals in terms of a relationship to inflammatory biomarkers. Elastase, IL-8, IL-1, HMGB1, and calprotectin are all reasonably well validated inflammatory biomarkers in inflammatory airways disease associated with infection, and particularly in CF, but also in bronchiectasis. And I think the message from this slide is, again, there are relationships to some of the organisms. Again, Pseudomonas being a driver, but also the presence of the microaerophilic and anaerobic bacteria having an inverse relationship. And in the lower right-hand panel, you can see there is some relationship between these inflammatory markers and Shannon-Weiner diversity. Again, little relationship to FEV1. We teased this out a little bit more with neutrophil elastase and looked at the relationship with various organisms and neutrophil elastase concentrations in these sputum samples. We divided this into quartiles, and you can see that those in quartile 1 for Pseudomonas compared to quartile 4 have a lower relative abundance. So the higher abundance or dominance of Pseudomonas aeruginosa is associated with a higher concentration of neutrophil elastase. And again, we see this inverse relationship with Streptococcus, Prevotella, and Veillonella, which you may consider as healthy commensals in the airway. And the conclusion from this side is that a more diverse airway is more likely to be less inflammatory and cause less damage to the airways. We tease this out further with an algorithmic, almost artificial intelligence approach, where we used a methodology called LASSO to agnostically interrogate the data. And you can see from the cells highlighted in yellow that there was a relationship using this methodology to two measures of inflammation, C-reactive protein and calprotectin, and richness and diversity to the presence of Pseudomonas aeruginosa and its relative abundance. This is an exploratory analysis, but I think begins to suggest that there may be important interrelationships between microbial diversity, particular organisms, and airways inflammation. So in conclusion, I hope I've convinced you that inhaled dry powder Toby is superior when given continuously compared to alternating months in terms of reducing microbial density in people with bronchiectasis, and there's no reason to believe that that would not be the same in CF. Molecular estimates of microbial diversity track the more conventional measurement of colony-forming units. Increased bacterial diversity is associated with reduced Pseudomonas aeruginosa and follows the treatment response. Next generation sequencing and wider omics using, in this case, inflammatory markers, but other important omics such as metabolomics are amenable to complexity analysis and artificial intelligence and have the potential to shed light on the important interactions between host and bacteria. These measurements, I think, present opportunities for holistic and integrated assessments of microbiological endpoints in clinical trials for future studies of infection in CF. I'd like to just thank my colleague Michael Tunney, Gisli and Arison, who's done a lot of the work shown in this presentation, and Andrew English for his artificial intelligence analyses. I'd also like to thank the main funders, the European Commission through the Innovative Medicines Initiative, and Novartis for their support in this study. Thank you very much, and I will hand back to the chair.
Hi, my name is D.B. Sanders. I'm a pediatric pulmonologist at Riley Hospital for Children and Indiana University School of Medicine in Indianapolis, Indiana. Thank you for logging on today to listen to my talk on the pros and cons of outpatient management of exacerbations. I'd like to thank the organizers for inviting me to talk today. Here are my disclosures, none of which are relevant to today's talk. When I was asked to talk about the pros and cons of outpatient management, I'm going to take that as the pros and cons of oral antibiotics. I'm going to jump right in and start talking about the pros, and then we'll come back to look at some of the potential cons. The first thing is that exacerbations are extremely common, and if we had to treat all of them with IV antibiotics in the hospital, we'd just have a ton of those events. So hopefully by using oral antibiotics, we can avoid IV antibiotics. The figure on the left shows the breakdown of the different antibiotics that are used during treatment of exacerbations. The vast majority use oral antibiotics. I believe there are over 45,000 courses of oral antibiotics a year in the US in people with CF for pulmonary exacerbations. On the right, we actually are treating initially with non-IV antibiotics, oral and or inhaled antibiotics. Essentially for everybody 6 and under, we begin with oral antibiotics, 97% of exacerbations there. That goes down as FEV1 declines get longer, but even with the largest FEV1 declines greater than 10%, we're still treating with oral antibiotics 3/4 of the time. Another potential pro is that we can maintain lung function by treating with oral antibiotics. So Jordana Hoppe completed a study of our 2 pediatric CF centers and found that first of all, again, we were using oral antibiotics a lot. 3/4 of our school-age children received at least 1 course of oral antibiotics in 1 year for an exacerbation. When we looked at FEV1 percent predicted in the 6 months prior to treatment, the average highest FEV1 during that time period was 96% predicted. If we look at the percent recovery, we recovered nearly 100% of that baseline, 99.6, though there were some patients who were treated with oral antibiotics who didn't recover that lung function. I would point you to this poster by Michael Schechter at this year's CF conference that looked at exacerbations treated either with non-IVs, oral and or inhaled antibiotics compared to no antibiotics identified at clinic visits in the CF Foundation patient registry. Each of the numbers here indicates the odds of recovery back to baseline. And for essentially every acute decline in FEV1, age group, and baseline FEV1 severity, the odds of recovering back to baseline were greater than 1 and statistically significant. So for even small declines in FEV1 of 5 to 7% predicted loss, the odds of recovering back to that baseline were 60% higher in the group treated with antibiotics compared to the group treated without antibiotics. Now for some cons, can we avoid hospitalizations? When we did a similar study as the last slide looking at exacerbations identified at clinic visits in the CF Foundation registry, we found that those who were initially treated without antibiotics, about 24% received IV antibiotics in the next 90 days. But when we looked at those treated with oral and or inhaled antibiotics, 23%. So we didn't really reduce the frequency of IV antibiotics in those 90 days after that initial clinic visit. When we looked at the STOP OB observational data where patients who are adolescents and adults who were enrolled at the time of the start of IV, we saw that nearly half of all participants and 3/4 of adolescents had received oral antibiotics initially. So these may represent failure of oral antibiotics and that these hospitalizations cannot be avoided. Wayne Morgan also looked at recovery of lung function after declines in FEV1. He used a little bit larger declines. So he looked at response to greater than 10% acute declines in FEV1. He found that about 2/3 were treated with antibiotics. This figure from his paper shows the odds of recovering back to baseline for a given treatment. And compared to not treating with antibiotics, any antibiotics helped with the odds of recovering back to baseline. But for hospitalization, the odds were much higher and statistically significantly higher than for oral antibiotics. So these slides call into question, how much are we benefiting from oral antibiotics? Yes, there's some, but it looks like other treatments may be even better. I also look at secondary analysis from the EICE data, the early event intervention in CF exacerbations, led by Noah Lexton and Chris Goss. In that study, they followed adults and adolescents with CF. The exacerbation was determined either by usual care, when the participant called and let the clinic know, or early intervention, where the clinic team was notified that home spirometry had detected a fall in FEV1, or home symptom detection had recognized an exacerbation. The goal was to avoid FEV1 decline by detecting exacerbation early. While they did find more exacerbations in the early intervention arm, they were not able to show that FEV1 decline could be avoided. And actually, recovery to baseline after exacerbation was less likely in the early intervention group. And in that group, they were more likely to receive oral antibiotics than IV antibiotics versus the usual care arm, which were more likely to be treated with IV antibiotics. Last year, Eden van de Vanter presented a secondary data analysis that looked at changes in FEV1 after the prescription of antibiotics in the EICE participants. And they looked according to the FEV1 drop prior to treatment. So if there's less than a 5% initial drop, 5 to 10%, or more than a 10% drop. Each line here represents an individual participant's home spirometry results, but the solid lines represent the average changes. And you can see that the average changes in white with IV antibiotics was increasing after start of antibiotics, but the orange line is actually decreasing. So after oral antibiotics were started, FEV1 was not significantly improving. And so it seems to be there's more of a benefit to IV antibiotics than oral antibiotics in these participants. So there are pros and cons, and the question is, do we have the right balance? I should note that all the studies I've mentioned have been retrospective analyses or registry analyses. There actually have been no interventional trials of oral antibiotics in people with CF. In addition to balancing the pros and cons of how much benefit we're getting, we also want to avoid antimicrobial resistance and the adverse drug toxicities, such as nausea, vomiting, diarrhea. And we want to improve clinical outcomes. So the question is, are we getting that balance right? If we look outside CF, there is maybe indication that we could be avoiding some oral antibiotics. So I typically ask families to call after 4 or 5 days of cough, and we often prescribe antibiotics at that time point. But in children without CF, nearly half are still coughing at 10 days after viral illnesses. And so if most of our exacerbations are caused by colds, why am I expecting the cough to be gone by day 4 or 5 in people with CF, when in people without CF, they're coughing for nearly 10 days or more? Additionally, there's a recent interventional study of oral antibiotics in non-CF bronchiectasis, not in CF, but by day 14 in the placebo group, nearly half of children had resolution of their symptoms. So if that were true in CF, does that mean that if we could identify the exacerbations correctly, that we could avoid antibiotics in those who are destined to go on to have resolution of their symptoms? So we're going to try and answer that question, and we're just starting the Streamlined Treatment of Pulmonary Exacerbations in Pediatrics, or STOP-PED study. And we think this is where we want to go. This is eventually the study we'd like to do. There are some few questions that we'll go through that I think we have to answer before we undertake this study. We would like to enroll children when they're at their well baseline. At the time of early recognition of exacerbation symptoms, we'd like to randomize to either immediate antibiotics, where we would ask participants to increase their airway clearance and start 14 days of oral antibiotics, versus the tailored therapy group, where we would try and avoid antibiotics by just starting increased airway clearance, increased frequency of airway clearance, and then start antibiotics only if symptoms are worsening or if they're not improving within 7 days. Before we can do that study, we need to address some important questions, and we're going to do that hopefully through a pilot study that we're beginning. Will a watchful waiting approach be acceptable to parents and providers, where we try and avoid antibiotics in that tailored therapy arm? Furthermore, if we take this watchful waiting approach, will we actually reduce antibiotic exposure? And these are two questions that we don't know yet and are going to have to address with our pilot study. So the overall goals of the pilot study we're just beginning is to assess the feasibility of a future multi-center randomized study of the timing of antibiotic use in outpatient exacerbations, as well as to obtain data for designing that future study. The current study is going to be a randomized controlled open label study of 120 participants who are school-aged, enrolled when they're well, and followed through one randomized exacerbation. Here's a schematic of what it's going to look like. So participants are enrolled when they're well. At the sign of early respiratory symptoms, we ask them to call us or let the study team know at a clinic visit. If symptoms are too sick, they'll be excluded, but can remain in the study once they've recovered for a future exacerbation that may be randomized. If symptoms aren't too severe, then they'd be randomized to the two groups I mentioned before. The tailored therapy group, they'd start increasing the airway clearance alone, versus those in the immediate antibiotic group, where we would do the increased airway clearance frequency as well as start the antibiotics. We'll have a final study visit after 28 days, and after one exacerbation is randomized and that study visit is completed, they'll be out of the study. Our primary assessment of feasibility and whether we can move on to that future study is to determine if we can avoid antibiotics in the tailored therapy arm during the 28 days following randomization. There are some secondary feasibility assessments, willingness of parents and participants to enroll, have treatment randomized, the feasibility of detecting symptoms early enough to do the randomization, as well as estimating the proportion of exacerbations that meet our randomization criteria and participants who experience a randomizable exacerbation. We will also collect information on potential future endpoints for the randomized controlled trial, including FEV1, symptom score, and treatment burden, or burden of the respiratory illness. We'll collect safety data, including antibiotic-associated adverse events, as well as the need for additional antibiotics. So I think one of the key things we needed to figure out was, can we randomize an exacerbation, and what criteria determined that a patient is too sick to be randomized? We came up with these criteria based on feedback from parents of children with CF as well as CF providers. So exacerbation may be randomized if there's been a new cough for between 1 and up to 7 days. But exacerbations are too severe, the patient's too sick, if a cough is constant during the day or waking from sleep, there's shortness of breath impacting usual activities or at rest, fatigue or low energy lasting more than 4 days. Additionally, if patients come to clinic, we have additional exclusion criteria, including FEV1 drops greater than 10% from baseline, saturations below 90%, new crackles on auscultation or increased work of breathing. And as I mentioned, these criteria were developed through extensive focus group to make sure that, that we thread that needle right and don't try and randomize symptoms that are too severe. Once an exacerbation has been determined to be randomizable, we need to know if the participant agrees to randomization. If yes, then they'd be randomized to the two groups I mentioned. The antibiotics would be chosen by the primary CF provider that we would ask at the beginning of the study and update throughout. If the event is not randomizable or the participant declines, then that exacerbation will be managed by the clinical team, but the participant can stay in the study for future events. During exacerbation, we're going to follow participants very closely. We're going to have regular contact with this research team. We're going to ask participants to complete a symptom score, treatment adherence, and adverse event report. And then at day 28, we would do a study visit. Now with the pandemic, they may be in person or remote, and then the participant would exit from the study. But again, participants can choose to return to clinical care at any time. We developed criteria for additional therapy. If they're in the tailored therapy arm and haven't started antibiotics yet, then we would add antibiotics. But if they're already on antibiotics and they're meeting this criteria, then they would return to clinical care. These criteria were also developed with focus groups of parents and CF providers. So we would prescribe additional interventions if cough is worsening for more than 4 days, cough is stable but not improving for more than 7 days, cough is improved but not resolved after 2 weeks on the study, and then if the participant develops shortness of breath impacting usual activities at any time, then they would escalate care. So the conclusion of my talk that, first of all, outpatient management of exacerbation occurs very frequently. All the pros and cons are based on retrospective observational data, but we're going to try and address this by being the first prospective interventional study of outpatient pulmonary exacerbation management in children with CF. I'd like to thank the Stop Peds study team, which includes Margaret Rosenfeld, who's my co-PI, Edith Zemanek and Jordana Hoppe and Wayne Morgan, who are the rest of the core PIs. We have a fantastic coordinating center through the University of Washington. I should also mention Lisa Bendy and Sharon McNamara, our lead research coordinators, and funding through the CF Foundation. So thank you for listening to my talk. Thanks again to the organizers for inviting me to talk today.
Hi, my name is Sonia Helshi, and I'd like to start by thanking the organizers of this year's NACFC and of course our session chairs. I have nothing to disclose related to this presentation. Today I'm reporting on the primary results of the STOP2 randomized trial of IV antibiotic durations in CF pulmonary exacerbation, and I'm doing so on behalf of my co-investigators, Patrick Flume, Christopher Goss, DB Sanders, Dutch Van de Vanter, and Natalie West. We know that pulmonary exacerbation is important and detrimental in CF. They're common, and in fact, the recent CFF patient registry has shown that over 40% of adults in 2018 experienced a pulmonary exacerbation, but the 2009 exacerbation care guidelines show that there really are limited data to define optimal treatment decisions. And as a result, IV antibiotic therapy to treat pulmonary exacerbation really varies widely in the United States. And here on the right panel, you can see treatment duration, IV treatment duration for exacerbations from the registry data. And you can see there's a mode at 14 days, but otherwise there's also a lot of variability in how long people are treated for an IV antibiotic, with IV antibiotics for an exacerbation. So standardized treatment of pulmonary exacerbation in CF is the full name of the STOP2 trial. There was a pilot observational study named STOP, which helped design this study, but thus this being STOP2. And the objectives are to evaluate the efficacy and safety of differing durations of IV antibiotic treatment for pulmonary exacerbation in adults with CF. It's a multi-center randomized controlled trial, and it was open label. We designed it to include adults with CF who are 18 years or older being treated for a pulmonary exacerbation requiring IV antibiotics. We didn't have any other definition of the pulmonary exacerbation other than physician decision to treat with IV antibiotics. And the design is unique in that it's really two studies in one. And how we did that was we evaluated the response from start of treatment to day 7 to 10. That was the visit 2 in the STOP2 trial. Day 7 to 10 of IV antibiotic therapy, and we evaluated percent predicted FEV1 change and also symptom response as measured by this instrument called the Chronic Respiratory Infection Symptom Score. And we were looking for improvements in FEV and reductions in CRIS to qualify someone as what we called the early robust responders, or the ERR grouping, or someone who didn't have these improvements in lung function and symptoms, and they were deemed the not early robust responders, or the NERR. And the full design has been reported and published. So early robust responders were defined as those having at least an 8% predicted FEV1 improvement and a CRIS symptom reduction of 11 points or more at this visit 2, at the visit right where randomization was conducted. And that 11-point improvement in CRIS is the minimally clinically important difference for the instrument. Those allocated to the ERR group were then randomized to either 10 or 14 days total IV antibiotic duration. And those remaining participants, so you can see on this grid here, those people who didn't have both the 8-point improvement in FEV1 and the 11-point reduction in CRIS, those remaining NERR participants were randomized to 21 versus 14 days of IV antibiotics duration. And this design was born out of a need to really find a balance between patients and physicians who were worried about too long of a treatment on one hand, if they were responding well and feeling great and having big improvements in lung function and symptoms, versus those who had a fear of being treated for really too short of a duration if their symptoms and their lung function was not where they needed it to be by 7 to 10 days of IV treatment. The primary endpoint was measured 2 weeks after scheduled completion of IV antibiotics, and the change in percent predicted FEV1 from the start of treatment to this 2 weeks after cessation was the primary endpoint. CRIS symptom score was also measured along the same time scale. Weight, need for additional antibiotics, time to the next pulmonary exacerbation is an endpoint that we will get as we merge these data with the CFF patient registry going forward, and of course adverse events. There were some exclusion criteria: treatment with IV antibiotics within the previous 6 weeks, admission to the ICU for a current pulmonary exacerbation, pneumothorax, massive hemoptysis, ABPA, greater than 2 weeks of prednisone, organ transplant, or active antibiotic treatment for NTM was considered exclusionary criteria. Some other design elements for the STOP2 trial: treatment could be both at home or inpatient, any combination of and that was up to the physician and patient discretion. Airway clearance and chronic medication were encouraged. That's per CF Care guidelines for treating exacerbations. Antibiotic dosing and selection guidelines were provided to all the site investigators to try to standardize that a little bit, and that was based on the most recent microbiology, respiratory microbiology culture results. And steroid initiation, if it was going to be started for treating the exacerbation, was encouraged to be started prior to randomization. And there were randomization strata to ensure some balance across some of these key parameters. And the randomization strata included percent predicted FEV1 at the start of the treatment, greater than or less than 50% predicted were the two strata. History of pulmonary exacerbation, location of the treatment, whether or not it was exclusively home versus any days in the hospital, and whether or not there were steroid use by the time of randomization at that visit to point. So 58 sites enrolled participants, 57 in the US and 1 in Canada, and they were enrolled between July of 2016 and January of 2020. 1,062 were screened, 982 were allocated. So here's the schema again of the change in CRIS versus the change in percent predicted FEV1. So you can see this breakdown of how the participants fell and where then they were allocated. And 277 fell in this ERR grouping, and those were the 277 randomized to either 10 or 14 days. Here you can see baseline characteristics and demographics by the treatment group and the ERR, and then overall. Overall, ERR participants were 27 years of age and had a mean percent predicted FEV1 of 50 at the time of enrollment, which was the start of the treatment. The majority had greater than or equal to 2 pulmonary exacerbations in the prior year. Less than 5% were on a highly effective modulator therapy, and about 15% were treated exclusively at home. About 10% started steroids to treat the pulmonary exacerbation, and we observed balance across the two groups, the 10 versus the 14 days. Here you can see a histogram of the actual IV treatment duration each participant received. I mentioned this was open label, so while participants were randomized to a duration, they certainly could go off protocol. The shaded region here, you can see if you were randomized to ERR 10 days, that's plus or minus 1 day, and similarly, you were within protocol for 14 days, plus or minus 1 day. In the ERR group, in the antimicrobial treatments were more likely to be of excess duration in that 10-day treatment group, where all 14 went long. The violations went long outside of the 11-day window. And duration deviations in the 14-day treatment group were both shorter. 12 were too short and out of protocol, and 9 were too long in that 14-day group. But in general, you can see the mean treatment duration was 10.4 days as compared to 13.9 days, and the withdrawal rate was low. So here's the primary endpoint, absolute percent predicted FEV1 change from IV start to 2 weeks after cessation of IV antibiotics. And you can see that the 14-day arm had a 13.4% predicted FEV1 increase. The 10-day group had a 12.8% predicted FEV1 increase. This translates to a treatment difference of minus 0.65, where the 10-day arm was minus 0.65% predicted FEV1, less than 14 days. And this was a non-inferiority design study, so there was a pre-specified margin where if the 10-day arm were more than 3.5% predicted worse than 14 days, it was deemed inferior. The p-value was 0.0164, which rejected the null hypothesis that 10 days was inferior to 14 days. So in favor of the alternative hypothesis that 10 days is indeed not inferior to 14 days. We conducted some sensitivity analyses. These were predefined sensitivity analyses, and you can see again that all of those point estimates are within 1% predicted FEV1 of the 14-day group for the 10-day group, and the confidence intervals all exclude this non-inferiority margin of minus 3.5%. Secondary endpoints on the left panel, you can see reductions in symptom score, large reductions in symptom score in both the 10 and the 14-day groups with no difference between the two. And then on the right panel, you see mean weight change and 95% confidence intervals, and again, with no significant differences between the 10 and the 14-day groups. So I showed you the ERR data, and now you can see the remainder of these participants in this grid that didn't have the early robust response. That NERR group made up 705 participants, randomized to the 21 versus 14 days. And again, here you can see baseline demographics and clinical characteristics. Mean age here is almost 32. There was balance across the 14 to 21 days. I really wanted to show you kind of the total NERR group versus the total ERR group to show that there really isn't much difference in the two populations. In general, the NERR were a little bit older. You had 32 years of age was the average in the NERR compared to 27 years of age in the ERR. Baseline percent predicted FEV1 was almost identical, right at about 50% predicted, and so was number of pulmonary exacerbations in the previous year. There was slightly more CF-related diabetes in the NERR group, and more treatments were occurring exclusively at home in the NERR group, with almost 25% compared to 15% in ERR. Here's that slide showing the histogram of actual IV duration each participant received. So those randomized to the 14-day treatment were allowed plus or minus 1 day to be still within protocol. 11 individuals stopped treatments prematurely, while 42 went long in that 14-day arm. And in contrast to the 21-day treatment group, 52 participants had treatments that went short, so that was outside of the plus or minus 3-day window for the 21-day arm, compared to 8 who were treated for durations beyond the protocol window of 24 days would be the within protocol longest point in that NERR 21 group. And you can see the mean treatment durations was 15 days in NERR 14 and almost 20 days in the NERR 21-day group. So here's the primary endpoint, which is again change in FEV percent predicted from IV start to 2 weeks after scheduled end of IV duration. And that change was plus 3.4% in the 14-day group and plus 3.3% in the 21-day group. This translated to a minus 0.1% predicted FEV1 change, where the 21-day was a little bit less than the 14 days by 0.1% predicted. That confidence interval ranged from minus 1.3 to 1.1 with a p-value of 0.56. So no evidence that 21 days was superior to 14 days in terms of lung function improvements. And the predefined sensitivity analyses are also support that same conclusion. So here are the secondary endpoints in the NERR groupings. This is again mean CRIS change with 95% confidence intervals, large changes in symptom scores, improvements in symptom scores, no significant difference between the 14 and 21 days. And then improvements in weight, there were improvements in weight gain, but again, no significant difference between 14 and 21 days. Here's adverse events and also retreatment with IV antibiotics. So I'm showing both ERR and NERR. In general, AEs were low. In the ERR group, there were 21 AEs amongst 18 participants in the 10-day arm, and 16 AEs amongst 12 participants in the 14-day grouping. There were very few serious adverse events, overall 4 in the ERR 10-day group and 1 subject in the 14-day group, and all thought to be unrelated to treatment. In the NERR group, there was a nominal increase in the number of AEs. In that 21-day group, there were 73 AEs amongst 47 participants compared to 40 AEs in 33 participants in that 14-day group. And primarily, the most common AEs observed were GI disorders, fever, elevated liver function tests being the most common. So in conclusion, among those with an early robust response to IV treatment, 10-day antibiotics really is not inferior to 14 days. And for those with a less robust response, 21 days is not superior to 14 days. Our primary endpoint was lung function, but we also observed no differences in symptom recovery, weight gain, antibiotic retreatment, or AEs. We cannot infer that there is equivalence of the 10 days versus the 21 days of antibiotics. It's important to point out that the durations tested clearly were in 2 very different populations, and so we can't make that direct comparison of the 10 versus the 21 days of antibiotic duration. And as mentioned, the adverse events were relatively rare and didn't differ among treatment durations. So what does this tell us? I think it tells us that a standard treatment duration is possible. 14 days, clearly, 10 days is not inferior to 14 days, and 21 days is not superior to 14 days. So going forward, I think it's possible to standardize a treatment duration in pulmonary exacerbation, especially in research and trying to look at other treatment parameters without having to worry about variable antibiotic durations confounding results when trying to really control other treatment parameters. And what this may also do is entice drug development in this area. What we like to say is kind of thus far exacerbation treatment has kind of been the Wild West in the US, and it's been really tough to think about trying to bring therapeutics development into the space when very little is controlled for in terms of standardizing treatments. And so it makes it really hard to think about looking at these results and looking at new therapies without addressing confounding. And so this is a really important step forward. There are several next steps, a couple predefined sub-studies looking at cost and quality of life in the STOP2 participants. Sputum microbiome and a viral panel looking at the microbiome and various viral panels and how it may associate with outcomes. And then we will eventually merge these data with CFF patient registry data to look at long-term outcomes. And there are additional analyses looking at inflammation using the CRP as a marker, site of treatment, hospital versus home, steroid use, and others. So I'd like to acknowledge, obviously, all of the patients and families who participated in the STOP2 trial, the sites, the PIs, and the RCs, the STOP2 study team at the TDN Coordinating Center, the CF Foundation, which provided grant funding, and Bruce Marshall, who's been supportive of the STOP program from the beginning, and the CFF Patient Registry. So with that, I look forward to questions and the panel discussion on October 23rd. Thank you.
Hi, my name is Lindsay Caverly. I'm a pediatric pulmonologist at the University of Michigan, and today I'll be speaking on what we've learned about infection during exacerbation from culture-independent technologies. There are no relationships to disclose related to this presentation. Over the next 20 minutes, I'll first review some knowledge gaps regarding CF pulmonary exacerbations and how culture-independent technologies have the potential to address these knowledge gaps. I'll then briefly review some of the common culture-independent technologies that have been applied to studies of CF airway infection and exacerbations. And then I'll review some of the key findings from culture-independent studies of CF exacerbations, including what are and what are not potential microbial triggers of exacerbations, as well as the implications for clinical care, including antibiotic treatment. Finally, I'll conclude with areas of future study. Please consider submitting any questions throughout the talk that you may have into the Q&A box to be considered for the live panel discussion on Friday, October 23rd from 11:30 a.m. to 12:30 p.m. In general, CF pulmonary exacerbations are thought to arise from a perturbation in the cycle of infection, inflammation, and airway mucus obstruction that characterizes CF lung disease. Treatment of exacerbations with therapies including antibiotics and airway clearance leads in the short term to improvement of symptoms and lung function recovery in the majority of cases. But work by D.B. Sanders and others has identified that a significant minority do not recover as expected following exacerbation treatment for unclear reasons. Additionally, over the long term, exacerbations are important contributors to lung function decline. The challenge for culture-independent studies is to provide insight beyond what's been gained using culture-based methods in addressing knowledge gaps in pulmonary exacerbations, including how to better understand pathophysiology of CF exacerbations, and can we better manage CF exacerbations with potential targets for improvement, including optimizing antibiotic selection, dosing, and timing. Can we predict exacerbations and intervene to prevent them from occurring? And ultimately, how do we improve outcomes of exacerbations for people with CF? Culture-independent analyses of CF airway samples can take multiple forms. I'll talk mostly today about DNA-based approaches. These most often involve amplicon-based sequencing, such as sequencing of regions of the 16S ribosomal RNA gene. Amplicon sequencing is followed by taxonomic identification against a reference database to provide data on the bacterial community members and relative abundances. Quantification of the amplicons can also be performed using techniques such as quantitative PCR. In contrast, instead of amplifying a single gene, whole genome shotgun sequencing or metagenomics involves sequencing of the entire mixed DNA extract from a sample, followed by identification against reference databases. In addition to identifying bacterial community members, whole genome shotgun sequencing can also provide information on virulence genes, strain level identification, and metabolic capabilities. I'll also talk a bit about studies that have used protein and metabolite-based approaches, both of which are mass spec-based technologies. First, how does culture-independent profiling compare to culture-based profiling of CF respiratory samples? Concordance and identification of traditional CF taxa between culture-independent and culture-based profiling was assessed in this study of 945 CF sputum samples. Overall, concordance for traditional CF taxa identification is high, with the percent of time each genus was identified by both methods shown in the black circles. In the minority of cases, the sample had each genus identified with only culture, light gray, or only sequence-based, dark gray. Culture-based profiling in clinical labs typically involves use of selective media to identify the traditional CF taxa known to be related to CF exacerbations and lung disease. In addition to the traditional CF taxa, culture-independent studies have identified additional species, labeled non-traditional taxa here, as being both prevalent and abundant in CF airway samples of all types. The majority of these non-traditional taxa are obligate and facultative anaerobes, with the most common genera listed here. This figure shows the age-related median relative abundances of traditional CF taxa compared to non-CF taxa in BAL samples from 93 patients based on 16S rRNA gene sequencing. You can see that relative abundances of non-traditional CF taxa, mostly anaerobes, is highest in younger children, then declines as traditional CF taxa increase in relative abundance throughout childhood and early adulthood. And these changes parallel the decline in lung function that's seen over the same time frame. Over the next few slides, I'll talk about relationships between both traditional and non-traditional CF taxa in relation to pulmonary exacerbation. But first, I wanted to review some of the terms and abbreviations that I'll be using to describe these clinical states. CF clinical states can be broadly binned into baseline clinical health, which at some point transitions into exacerbation of symptoms. Once exacerbation is diagnosed and antibiotics are started, we'll refer to this as the treatment state. And finally, following antibiotic completion, there's a period that I'll call recovery, in which the microbiome is shifting back to a baseline state following the antibiotic course. This is an imperfect classification system, as we know that people with CF frequently have periods of waxing and waning symptoms prior to the formal diagnosis of exacerbation. But it's been a useful framework for culture-independent studies to investigate microbial triggers of CF exacerbations. So what have we learned about CF exacerbations? I'll start with a few points on what doesn't change with exacerbation, findings of which have challenged some prior conventional wisdom regarding microbial triggers of CF exacerbations. And I'll point you here to an excellent article by George O'Toole that explores these challenges to conventional wisdom that have come from culture-independent studies. And here I'll focus on the ideas that CF exacerbations are related to increases in total airway bacteria and/or increases in the abundance of CF pathogens, which then both decrease with antibiotic treatment. Multiple culture-independent studies, however, have shown that neither of these are the case. And a few of these studies I'll highlight here. First, in this study, the La Puma lab compared total bacterial load measured by qPCR of the 16S copy number between paired baseline and exacerbation sputum samples of 28 patients and found no difference in total bacterial abundance between these time points. Similarly, in this study, sputum samples from 17 patients were compared across the clinical states of baseline, exacerbation, treatment, and recovery, and neither total bacterial burden nor Pseudomonas aeruginosa burden differed across these states. Cuthbertson and colleagues similarly measured Pseudomonas burden across the clinical states and did not find changes across baseline, exacerbation, or with antibiotic treatment. But if increases in total bacterial load or Pseudomonas abundance do not account for the transition from baseline to exacerbation, then what does? Well, one common theme that's arisen from culture-independent studies has been associations between certain anaerobic genera and pulmonary exacerbation. In early work, Sibley and colleagues studied longitudinal sputum samples from people with CF over a 6-year time period using both culture-based and culture-independent approaches. In this cohort, members of the Streptococcus milleri group were the dominant species at the onset of about 40% of the exacerbations in this study, with some examples of these patients shown here, with abundance of Strep milleri in the open circles, Pseudomonas and staph in the closed circles. And both patient clinical improvement and reduction in strep density were seen with antibiotic treatment, shown in the colored bars below each figure. Similarly, in the same study discussed earlier of 28 paired baseline and exacerbation sputum samples, an increase in the relative abundance of Gamella, another anaerobe, was the most discriminative genus associated with exacerbation. Other work around the same time frame investigated potential mechanisms through which anaerobes may contribute to pulmonary exacerbations and identified potential roles for anaerobic metabolism in exacerbation pathophysiology. Quinn and colleagues used a Winogradsky-based capillary tube to model mucus-plugged CF airways, and with these tubes, incubation of longitudinal sputum samples in the model showed that pulmonary exacerbations were associated with a drop in pH and increases in relative abundances of fermentative anaerobes, including Prevotella, Vianella, and Fusobacterium. The same group, in a study led by Katrina Whiteson, measured CF breath metabolites with gas chromatography and identified elevated levels of this volatile metabolite 2,3-butane-dione in CF airways, shown here in red, compared to healthy controls in gray. These levels then decrease with antibiotic treatment for exacerbation. Metagenomic sequencing of sputum samples from these same patients then identified bacteria with the potential for 2,3-butane-dione synthesis, in particular Streptococcus. And the authors proposed a model through which 2,3-butane-dione may contribute to CF exacerbations, including potentially causing direct lung damage or by acting as a signaling mechanism to other bacteria, for example, triggering phenazine production by Pseudomonas. Finally, in this study of 109 bronchoalveolar lavage fluid samples, anaerobes were identified in the majority of BAL samples, and based on gas chromatography, were all associated with detectable levels of the short-chain fatty acids shown here in figure C, with higher levels overall seen in the BAL fluid of older children and adults, shown with the black bars. The investigators then used a bronchial epithelial cell model to demonstrate a dose-dependent increase in IL-8 production with short-chain fatty acids, including acetic acid shown here. These data demonstrate that anaerobes are both viable and metabolically active in the CF lower airways, and added to the evidence that anaerobes may play roles in CF lung disease, including exacerbation. However, other culture-independent studies have not identified common microbiome profiles across large populations. Coburn and colleagues performed a cross-sectional study of 296 patients in sputum samples across a wide range of ages, from young children through adults, as well as a range of lung disease stages and clinical states. In comparing samples across clinical states, they did not find differences in Shannon diversity of the bacterial communities between baseline and exacerbation samples in either children or adults. And similarly, there was no clustering of exacerbation samples shown in the open squares on the ordination, which would indicate common microbial signatures. This and other studies that have not identified changes in airway microbiota with pulmonary exacerbation are seemingly discrepant with some of the positive findings that I discussed earlier in the talk. However, one likely explanation for the lack of common microbiome signature across a large population is that the CF airway microbiome, and thus the changes that occur with exacerbation, differ by disease stage. In this study of 111 patients and 631 sputum samples, we identified increases in the summed relative abundance of anaerobes at exacerbation in blue compared to baseline in yellow. However, this was observed only in patients at early or intermediate lung disease stages, defined by percent predicted FEV1 greater than 70 or between 40 and 70, respectively. You'll remember from my earlier slide that relative abundance of CF taxa increases with advancing age and lung disease progression. Thus, patients at advanced disease stage are characterized by very low diversity bacterial communities with very low relative abundance of anaerobes. Additionally, using a summed relative abundance of the most abundant anaerobes in this study allowed for assessment of changes with exacerbation across a similar grouping of bacteria. And this unifies some of the prior findings of differences in anaerobes, including strep, prevotella, gamella, as there has not been identification of a single disease-causing species across studies. We've also learned from multiple culture-independent studies that the difference in airway microbiota between patients is greater than the changes within patients, which also helps explain why common signatures of exacerbation have not been found in some studies across patients. Recent studies have thus used longitudinal sampling to test within-patient changes in airway microbiota across clinical states. In this study of 6 patients and almost 600 sputum samples collected over a year's time, within-patient changes in sputum metabolites were identified with exacerbation compared to baseline. These changes included greater Bray-Curtis dissimilarity at stable compared to exacerbation states, or in other words, more microbial variability was seen in the stable state samples. The second panel shows that the exacerbation samples had greater metabolome diversity compared to stable state. Finally, within-patient changes in airway microbiome over the 14 days preceding pulmonary exacerbation were evaluated here with an LME model, and significant increases in the ratio of anaerobes to CF pathogens were observed in the days leading up to CF exacerbation, or time 0 here, which then trended downward with antibiotic treatment. Complementary to the ideas of within-person changes in bacterial community dynamics and metabolic activities with exacerbation, several studies have identified changes in bacterial co-occurrence and interactions. In this study of sputum samples from 6 patients over 10 years, reorganization of the bacterial co-occurrence patterns were seen between baseline and exacerbation states. In particular, there were reorganizations of interactions between Pseudomonas and anaerobes, which were observed to have antagonism at baseline, which was then lost at exacerbation. Finally, I focused so far mostly on studies to better understand the pathophysiology of CF exacerbations, and I want to end by highlighting a few points that we've learned from culture-independent studies that address knowledge gaps in antibiotic treatment in CF, particularly in thinking about why certain exacerbations are not followed by clinical recovery with antibiotic treatment, and why are the poor correlations between in vitro antibiotic susceptibility testing and clinical outcomes observed. First, Jorth and colleagues performed a study on 10 pairs of CF lung explants to evaluate regional differences in Pseudomonas phenotypes across 6 sites in each lung pair, with about 200 Pseudomonas colonies selected from each site. Consistent with prior work, each of these subjects was infected with a single Pseudomonas strain. However, considerable differences were observed within patients across lung regions, including differences in the Pseudomonas proteome shown here for 1 patient, and within patient differences in antibiotic resistance profiles across the lung regions. These regional variations in antibiotic resistance clearly complicate effective antibiotic therapy, particularly when an antibiotic decision is made based on limited sampling from the lung regions, such as occurs with a sputum sample. Efficacy of antibiotic therapy also often depends on the growth rate of the targeted bacteria. In this study from Diane Newman's lab, the team used heavy water labeling of sputum and mass spectroscopy to measure Staph aureus growth rates in 37 sputum samples from 16 patients. They found that Staph aureus growth rates in CF were between 2 to 100 times lower than typical in vitro growth rates. These rates were even lower with antibiotic treatment, and an increase in the rate prior to completion of antibiotic treatment was observed, shown here with the arrow on the x-axis. Better understanding these mechanisms and how they impact treatment of CF exacerbations are areas for future study. The final antibiotic treatment consideration involves the distribution of antibiotics throughout the lung. A recent study of microbiome and metabolome analyses of 3 lung explants from end-stage CF identified significant spatial heterogeneity of antibiotic distribution throughout the lung, shown here in the cross sections, with high antibiotic distribution in red and low in blue, and shown for azithromycin, piperacillin, and minocycline. Non-uniform drug penetration can be contributed to by reduced perfusion to non-ventilated areas, and for inhaled medications, by mucus plugging and airway obstruction. And all of these highlight the difficulties of uniform drug delivery for exacerbation treatment. So in summary, culture-independent studies of infection during CF exacerbation have not identified a single unifying feature of CF exacerbations. Changes with exacerbation vary between patients by age and by lung disease stage. However, there have been some common themes of the potential role for anaerobes in exacerbations. We discussed some of the challenges in antibiotic treatment and how culture-independent studies have helped shed light on why some of these challenges exist. And I wanted to highlight that there is ongoing work with the STOP2 study, and the STOP2 study samples will be analyzed for airway microbiome and metabolome associated with exacerbation, recovery, and treatment response. So these and other future directions will work to translate improvements in clinical care and outcomes, including exacerbation detection, prevention, prediction, antibiotic selection, dosing, and duration. Thank you.